Good evening, participants and delegates. Thank you for joining Shield Connect. Today we have Dr. Suman Sinha. Ma'am is the president of Obstetric Gynecological Society of Ranchi, and today she is going to take topic GDM and its management. So before we start with the session, let me give a quick introduction of our page Shield Connect as well as of our ma'am. So let me share my screen. So this is our page Shield Connect. You can go through shieldconnect.in and you can see that we have recently won 5 digital awards for this platform. And you can go through all the sections available in our page. The first section is the blog section where all the doctors, eminent speakers have written the blogs in this page. And then we have a webinar page where you can see recent webinars and you can click on see more. So like if you click on see more for today's webinar, you can see the webinar on this section, and on this comment section, delegates and participants, you can post your queries after the end of the webinar so that we can have a Q&A session with our speaker for the day. Then we have past webinars where you can see all the webinars that we have conducted in the past. Then we have also the awareness pages like PCOS awareness page, menopause awareness page, GDM awareness page. So if we click on any one of the page, you will find all the videos and blogs related to it. So like if you click on GDM, you will get all the information regarding GDM. Now we also have our leaders page where you can find all the profile of our top key opinion leaders. So if for today's webinar, Dr. Suman Sinha, so you can see her profile in our page also. Then we have a special day pages also. So when you click on any special day, you will get the information regarding it. So this is our page, and let me give quick introduction of our speaker, Dr. Suman Sinha. We are glad to have you, ma'am, on our platform. Ma'am is a senior consultant and obstetric gynecological section at AHIVF and Infertility Center in Morabadi, Ranchi from Jharkhand, and ma'am is also director of Advanced Care and Maternity Center. So, ma'am, we welcome you on our platform, and I will hand over the session to you, ma'am. Thank you.
Thank you very much. Good evening, everyone. Before I begin, I must thank Shield for giving me this very prestigious opportunity. And today I'll be talking to you on a very pertinent topic. It's actually very close to my heart, and it must be very close to your heart also. And this is about GDM, that is gestational diabetes mellitus, also coined by FIGO as hyperglycemia in pregnancy. So I'll be dealing with its definition, its management, obstetric management, and what are the complications, and how can we tackle this disease. So I start with my presentation. Yeah. Can you see my slides?
Okay. Yes, ma'am, it's visible, ma'am.
Thank you. So regarding gestational diabetes mellitus, as we all know, it is one of the most common medical complications of pregnancy, and it affects mother, fetus, and outcome of pregnancy also. Hence, its early detection is extremely necessary. So regarding its definition, we all follow FOXI guidelines 2021. So according to FOXI guideline 2021, GDM is defined as carbohydrate intolerance. Just a minute. Dr. Tarini, I'll be talking to you after 1 hour. Okay. Bye-bye. Thank you. Thank you. It is defined as carbohydrate intolerance resulting in hyperglycemia of variable severity with onset of first recognition during pregnancy. It is also defined in this way because it includes women with undiagnosed pre-existing diabetes as well as women with first onset hyperglycemia during pregnancy. FIGO recommends the term hyperglycemia in pregnancy, whether the diabetes is before pregnancy, during pregnancy, or even it is because of pregnancy. So finally, in broad spectrum, we can say that it is defined as carbohydrate intolerance, so variable severity with onset or first recognition during pregnancy. Whenever you see first time during pregnancy, and if you see any carbohydrate intolerance, then that can be defined as gestational diabetes mellitus. As we all know, pregnancy is a form of stress that can cause latent diabetes to manifest. In most of these cases, the carbohydrate intolerance will revert by the end of the puerperium. But what is the consequences of it? Though it reverts back by the end of puerperium, but this manifestation may be the first indication of diabetes yet to come, because after puerperium, when the diabetes gets controlled, you don't think that you're not going to suffer later on. Later on, also it has the consequences. So regarding its prevalence, globally, you'll be surprised to know that 1 in 10 pregnancy is associated with diabetes, 1 in 10, and 90% of which are Gdm. The prevalence of gestational diabetes varies worldwide and among racial and ethnic groups. Prevalence rates are higher in Blacks, Hispanic, Native American, and Asian women than in white women. The prevalence of gestational diabetes has been reported from 3.8% to 17.9% in different parts of India. Asians and moreover Indians are at greater risk of diabetes mellitus, and hence pregnant women are at higher risk of gestational diabetes. GDM is short with an increased risk of maternal and fetal short-term and long-term ill health. So we know the incidence in India is very high. In United States, it is 2 to 5%. In Asians, it is 8%. And look at in India, it is 14%. And more so, it is in the urban population, that is 17.8% when compared to the rural population, where it is 9.9%. So when I was looking at this chart, I saw that in Lucknow, which is the capital of UP, we have the maximum incidence of GDM, that is 41%, and in Kashmir it is the least, that is 3.8%. So let us understand, why is pregnancy diabetogenic? The patient who is not diabetic before pregnancy, whenever she becomes pregnant, what is the reason of becoming her gestational diabetic? It is because pregnancy is a state of diabetogenic state. Why? Because there are 4 factors involved during pregnancy. First one is insulin resistance. What happens during pregnancy? Placenta produces the hormones, and the hormones are human placental lactogen, cortisol, estrogen, and progesterone. They all are insulin antagonists. So what they will do, it will not allow insulin to act, and that is known as insulin resistance. And then another thing is that what happens, insulin is gets destructed by the kidney and liver. So the concentration of insulin also decreases during pregnancy. During pregnancy, there is increased lipolysis. What happens? Mother utilizes fatty acids for her caloric needs. So this she spares the glucose, and that glucose is in the blood. And why she spares the glucose? That is for her fetus. And there is also changes in gluconeogenesis. You know, for gluconeogenesis, alanine and other amino acids are required. And this is a very important gluconeogenic source in the mother. But during pregnancy, her fetus utilizes this alanine and other amino acids. So all are acting as insulin antagonists, and therefore, when insulin will not be acting, then what happens? There will be increase in level of sugar in the blood, and that will cause hyperglycemia, and that is the cause of gestational diabetes mellitus. And totally it is physiological, but in non-diabetic patient who can bear the stress of pregnancy, the insulin and the antagonist, they remain in a balanced state, whereas the patients who are prone to get diabetes later on, they they are not able to bear the stress, and the insulin level goes down and the insulin antagonist level goes up. This is the whole phenomenon of why the pregnancy is considered as a diabetogenic state. So regarding the short-term and long-term maternal and fetal complications due to GDM, what are the risks of this GDM? The risk is for the mother also and for her offspring also. So the mother, the risk during pregnancy is there is increased risk of preeclampsia. That is, it means that the increased risk of hypertension. And during labor, there is increased risk of cesarean section because the babies are mostly macrosomic, and that leads to cesarean section. So there is more chances of operative deliveries, and there is more chances of labor complications. And in the postpartum period, the patient is likely to have GDM in the recurrent pregnancies, and there is also a risk that she may develop type 2 diabetes later on. And what are the risks to her baby? The risks are congenital, neonatal, and the long-term outcome. The congenital risks are this gestational diabetes can affect the cardiac, has effect on the cardiac function, on the CNS, on the fetal programming. So the babies are macrosomic due to increased fat mass. You know that this insulin, when there will be resistance of insulin, what happens? Insulin also acts as a growth factor, and this growth factor leads to increase in the causes hypertrophy of the liver and the cardiac muscles. So the baby and even the tissues. So the baby becomes macrosomic. Now, what are the neonatal complications? The neonatal complications are baby might be born premature. They might be born with perinatal asphyxia. There can be RDS when the baby is born. Some metabolic complications may be associated like hypoglycemia, hypocalcemia, polycythemia, hyperviscosity, low iron stores, hyperbilirubinemia, and cardiomyopathy, which I have already said that the cardiac function may also be involved due to this increased blood sugar. And the long-term outcome of the offspring is baby, because are born macrosomic, then they have, because due to that they have the risk of becoming obese later on. They may suffer from type 1 diabetes, even type 2 diabetes, and there may be increased risk of metabolic syndromes. So this is one slide taken from the American Journal of Pediatrics, where they have broadly classified the complications: maternal complications, fetal complications, and the neonatal complications. The maternal complications are preeclampsia, infection, laceration, cesarean delivery, long-term sequelae, which we have already discussed, and the fetal complications are growth abnormalities, polyhydramnios, and fetal demise. The neonatal complications are due to macrosomia. There can be birth injury, hypoglycemia. They may have seizures. Hypoglycemia leads to seizures also, polycythemia. There can be electrolyte imbalance, hypocalcemia, hypomagnesemia, hyperbilirubinemia, and respiratory distress. So what are the risks of hyperinsulinemia? This hyperinsulinemia, I've already told you that it has insulin-like growth factor. So that will do organomegaly, and this organomegaly will mostly affect liver and heart, and that results in the macrosomic baby. It also causes decreased surfactant that can lead to RDS and asphyxia. Due to macrosomia, there is risk of birth trauma. There can be neonatal hypoglycemias because this insulin crosses the placenta and reaches to the baby, and baby this blood sugar, and the insulin, it crosses the placenta, reaches the baby, and due to that baby starts producing insulin from its own pancreas, and that causes neonatal hypoglycemia. There is risk of intrapartum asphyxia due to RDS, and there is increased erythropoietin, which leads to polycythemia. There is some skeletal anomalies also, which is very nice pictures have been shown. One is of first picture is of portal regression syndrome, and other is the sacral agenesis. So you can see how this increased blood sugar or during pregnancy can affect the mother and her baby. So it is urgent need and utmost and the gynecologist should take utmost care in diagnosing the gestational diabetes as soon as possible in the early trimester pregnancy, or as soon as patient approaches to her. So now I was talking about so many complications and everything. Now question comes now, how to identify these GDM patients? And they can be identified only by screening and diagnostic test. And for the purpose of making a clinical decision, it is better to screen your patients when they first appear to you. And for GDM, the oral glucose tolerance test, which we very well know as OGTT, is generally the diagnostic test of choice. And this test is usually administered at the first antenatal visit and between twice we have to do. Suppose in the first antenatal visit, you see that the blood sugar level is normal, then it doesn't mean that patient is normal, because here there are so many insulin antagonists by the placenta. So they try to keep the blood sugar level controlled. But when the later on what happens, gradually this antagonist effect is over, and the blood sugar becomes higher, and that is more apparent during the 24 to 28 weeks. So at that time, it is very important to screen the patient for diabetes. So for this, how to do this OGTT? Actually, we are not following this method. We will be doing the Dipsy method, but let me explain to you. This is the worldwide accepted screening method. What it is, a plasma blood sample is obtained following an overnight fast. Patient has to fast for overnight, and then a 75-gram glucose or 100-gram glucose is given, and further blood plasma is obtained after 1 hour, 2 hours, and 3 hours. And GDM is diagnosed depending upon the criteria used, if 1, 2, or more glucose levels are equal or exceeded. Actually, we are not following this, but it is accepted worldwide except in our country, because in our place the prevalence is very high of diabetes. So what are the screening methods? There are two methods, selective screening and universal screening. We are following the universal screening because our incidence of GDM is higher than the other countries. So this I have tried to show in the slides. Compared to the West, where the prevalence is only 3.8%, the figure in India indicate around 14%. Hence, Indian ethnic population is considered to be at risk, and universal screening has to be offered in the antenatal period. So when it has to be done, it is unwise to delay the testing beyond 28 weeks, since late detection reflects a lost opportunity for control. It is wise to offer the single-step Dipsy test, which we all are following, in the early trimester or at the very first visit. Because with this, we can pick up the 17% of cases before 16 weeks of gestation, indicating the significance of early testing and initiating early control for a better outcome. Even if the first trimester test report normal, the test should be repeated between 24 to 28 weeks of gestation, since the maximum incidence of flare up and development of GDM occurs in the phase of pregnancy. So what is this one-step test? How do we do it? To avoid multiple visits and multiple breaks, and this multiple breaks and multiple visits, what is the problem with it? We'll lose our patient. The patient will never come back. So whenever patient comes, we have to do our the screening test in one go. And for this, we salute to our Padam Shri, Dr. Sheshia and group, who has validated and um, validated and brought a very simple test called Dipsy Test in 2009. And this is a single step test both for screening and diagnosis. So how do we do it? It's very simple. 75-gram oral glucose load is given uh, without regard to the time of last meal. Patient doesn't have to be fasting, and 2 hours after that a venous blood sample is taken and GDM is diagnosed if 2-hour plasma glucose is more than 140 milligram per DL. And what is the beauty of this test? It avoids multiple visit and multiple samples. So I already told you it has been validated by Padam Sri Dr. Sheshia. He was from Chennai, and this was in 2009. And since then, we are following this. So what is the methodology of this test? I'm repeating this again and again because it is very important. So single test is performed using 75 gram of oral glucose and measuring blood sugar 2 hours after ingestion. So 75 gram glucose is be given orally after dissolving it in approximately 300 ml of water, whether the pregnant woman comes in fasting or non-fasting state. So irrespective of the last meal, we don't ask to the patient, have you taken meal or are you fasting? We don't have to ask anything. Just give her 75 gram of glucose and give her 300 ml of water, or tell her to bring a bottle of water, and so that she can dissolve this 75 gram glucose packet into that 300 ml and drinks it within 5 to 10 minutes. So it is not that take the glass of water and sit and talk. It's not that. You have to finish it within 5 to 10 minutes and then be seated where you are. Much movement is not allowed. And then a plasma standardized glucometer should be used to evaluate blood sugar 2 hours after the oral glucose load. And if vomiting occurs within 30 minutes of the oral glucose intake, maybe a patient is fasting and she has taken, drank the solution very fast, it's likely that she might vomit. So if she has vomited within 30 minutes, the test has to be repeated next day. But if vomiting occurs, so we have to be very precise in asking the patient, what was the time when you vomited? And if she vomits after 30 minutes, then this test continues. And the threshold blood sugar level of 140 or more than 140 but less than 199, 299 is known as Gdm. So we have done this. So benefits of fasting on good compliance serves as screening and diagnostic tool. Compliance, why? Patient will not run away because he never comes. No, when you call her that come for next day, when you call her, she will not come. So in one go, you complete your test. So this is the interpretation of Dipsy test. So if 2 hours after meal, the blood sugar is less than 120, okay, then it is known as normal. If 2 hours after meal, it is between 120 to 139, then it is gestational glucose intolerance. And if 2 hours after meal, it is between 140 to 199, then it is known as Gdm. And if it is more than 200 after 2 hours, it is over diabetes mellitus. What does it mean? It means that patient was diabetic before pregnancy. Okay, but the management will be same and the term will be same. C will be also known as gestational diabetes or hyperglycemia in pregnancy, but patient was diabetic. So you have to take a proper history also, that have you ever done your blood sugar testing before you're pregnant? Are you taking any drug for the diabetes mellitus? So you have to be very careful in taking history of the patients because they don't tell you anything. You have to ask them. Now, other criteria which is followed in the other parts of the world, they are known as NDDG, National Diabetes Data Group, which we call as NDDG. Another one is American Diabetes Association, the ADA. Then comes the WHO, and then is the Carpenter and Houston method. So this is the NDDG group where a fasting sample is taken, then 1 hour, 2 hour, and 3 hour. 1 hour fast, and in the American Diabetic group, 3 samples are taken: fasting, first hour, second hour. In WHO, only 2 fasting, and this after 2 hours, similar to something similar to us. And then in the Carpenter and Houston method, this is 4 fasting, first hour, second hour, and third hour. So look, it is so cumbersome. 4 times. So who is going to give 4 times blood sample? Nobody gives. So so we are not following this, but we should highlight the other GDM criteria also. So in this, see this star says that in NDDG group, the ADA group, and in the Carpenter and Houston group, if 2 criteria are met, this is known as GDM. Suppose this is fasting, this fasting is raised, this is the upper limit, if this is 105 or more than 105, or 165 more than 165, then it is known as the GDM. Whereas here, this is cross type something. So in the cross type, what they say, even if one test is abnormal, and that is 126 or more than 126, then the patient is labeled as GDM. So this is the interpretation of, we are also doing OGTT when patient, actually when Dipsy test becomes positive, we can confirm our test by doing OGTT, but we are not doing this. Yes, I think we are doing this. Fasting, the cutoff is 95, 1 hour is 180, 2 hours is 155, and 3 hours is 140. So if one value is abnormal, it is impaired GTT, and if more than one value is abnormal, GT. This is the GDM. So what are the other screening methods? There are also other screening methods, that is HbA1c, glycosylated fructosamine, glycosylated albumin, and fasting blood sugar, which is a very low sensitivity. We are not doing this. We are doing HbA1c, but this is not a screening method. This is this HbA1c. I will tell you what it is and why it is done. HbA1c is the product of non-enzymatic glycosylation of hemoglobin and reflects the average blood glucose levels for the preceding 2 to 3 months. Normal range is between 5.3 to 6%. So the upper limit of HbA1c being 6%, and a level of 8% reflects mean glucose level of 180 mg per dl. So these are the implications of the congenital malformation. Why we do, when we suspect patient to be suffering from GDM, we like to do one HbA1c to know her status of blood sugar of the previous 3 months. And if we see that the HbA1c report is 6.5%, up till 6.5%, we are not worried, because there is absolutely no risk of congenital malformation in the baby. Whereas if HbA1c is 8% or less than around 8%, then the risk is of 5%. And if it is more than 10%, then the risk is very high, 25%. And maybe we have to terminate this pregnancy. So to evaluate our patient and what will be our next step of management depends upon the maternal HbA1c. So these we are not doing. So I'm just omitting this. We are following the one-step procedure. So what is one-step procedure? Where we straightway give 75 grams of glucose and do the interpretation. Whereas in two-step test, what happens? So initially 50 grams of of glucose load is given, and 1 hour after the 50 gram of glucose, the blood sugar is tested, and if it is more than 140, then the two-step test. Then what happens? Then 100 gram of glucose is given, and 3-hour oral glucose tolerance OGTT is done. So we are not doing. So this is not of our concern. So this we have already read. Okay. So in this one-step approach with 75 gram OGTT, what we see, the normal fasting is 92, and 1 hour plasma glucose is 180, and 2-hour plasma glucose is 153. This is one-step approach with 75 gram glucose, done followed in other part of the world. And this is the Carpenter-Houston criteria. I'm not going to go in detail of this. So I'll skip this. What are the advantages of single test procedure? Advantage is patient does not have to be fasting, causes least disturbance in a pregnant woman's routine activity, serves as both screening and diagnostic purpose. Yes, we are screening also the patients and we are diagnosing also patients, and extremely useful for diagnosing GDM in the present context of COVID-19 pandemic. Yes. So now comes the another important part of GDM, that is regarding its management and what are the guiding principles. These all have been taken from Foxy itself. So all pregnant women who test positive for GDM for the first time, what you do? Should we start with the drugs? No, not at all. Should be started on medical nutrition therapy. Medical nutrition therapy is the patient has to take nutrition given by the dietitian or by the doctor, and she has to do physical exercise, and this has to be done for 2 weeks without any drug. Just they follow the diet, their diet control. They have to control their diet and do physical exercise for 2 weeks. And what type of physical exercise? The women should walk or exercise for 30 minutes, at least for 30 minutes a day. And after 2 weeks on MNT and physical exercise, 2-hour postparental blood sugar should be done. Thus, GDM is managed initially with MNT and physical exercise, and if it is not controlled with MNT, then either metformin or insulin is added to the MNT. If 2-hour fasting PP blood sugar is less than 120, it means that patient diabetes has been controlled, and this test has to be repeated every month during the 2nd and 3rd trimester, and more follow-up tests can be done as recommended by the treating physician. But if this 2-hour PP blood sugar is more than 120 or more than that, medical management either with metformin or with insulin has to be started as per guideline. So what are the principles of MNT? That is healthy eating during pregnancy. Diet control, I said, actually the word diet control should not be there. Patient has to have healthy eating, but that has to be low in carbohydrate. All pregnant women with GDM should get medical nutrition therapy as soon as diagnosis is made. So MNT from GDM primarily involves a carbohydrate controlled balanced meal plan, which promotes optimal nutrition for maternal and fetal health, adequate energy for appropriate gestational age achievement, and maintenance of normoglycemia. Diet should be balanced as follows. Carbohydrate should be only 50% to 60%. Protein should be between 20 to 25%, and fat 25%. So if we give hypocaloric diets in the obese women with GDM, for them it is okay, their blood sugar will be controlled, but that can adversely impair the growth of their fetus. And besides that, they may suffer from ketonemia or ketonuria. So as per Indian ICMR guidelines, for an average weight gain of 10 to 12 kg, an addition of 350 kilocalorie per day above the adult requirement is recommended during 2nd and 3rd trimester. Severe caloric restriction is not recommended. So this again, I have taken a beautiful slide where it tells you what should be caloric intake per kg per day depending upon the BMI of the patient. If the BMI is low, suppose it is less than 18.5 kg during pregnancy, if you see that, then what will you do? You have to see that her weight gain should be between 12.5 to 18 kg. And then the caloric requirement is 35 kilocalorie per kg per day. If patient is of normal BMI, that is from 18.5 to 24.9, then the weight gain, we all know it is from 11 to 16 kg, and there we will allow 30 kilocalorie per kg per day. But if patient is very obese, he is obese like more than 30 kg, the BMI is more than 30 kg, then what we do? The weight gain advised is very less. It is between 5 to 9.1 kg only. And we then advise 25 kilocalorie per kg per day. So the diet should include carbohydrate, but it has to be complex carbohydrate. That means it has to be high in fiber, and simple sugars should be avoided. The total calories should be contributed by about, we have read that. Now, this is the management plan by the Foxy. So if patient is pregnant with GDM, what we do at the very first, we advise her medical nutrition therapy and physical exercise for 2 weeks. And after 2 weeks, we do a PP blood sugar. And if PP blood sugar is less than 120, then we are not worried, and we continue, tell her to continue with MNT and the physical exercise. And then we have to monitor the 2-hourly blood PP blood sugar every month till term. Whereas if the blood sugar is found to be more than 120 or even 120, then we have to start with oral anti-diabetic, that is metformin or insulin therapy. So, and we have to monitor blood sugar every 3rd day, at least twice in a week, at least. And this has to be maintained up till the delivery, twice weekly. So metformin and insulin treatment depends upon the sugar levels of the pregnant women with GDM, and it is usually given when GDM is not controlled on MNT. So insulin is the drug of choice, and metformin can be given. Metformin is given only after 20 weeks of gestation for medical management. But for insulin, it can be started anytime during pregnancy. And actually, we start with metformin because our patients are not ready to insulin. If we say that you have to take insulin, they are very reluctant about it. So we start with, I'm talking about myself, and I have treated so many patients with metformin, and I have not seen any problem with the fetus. No congenital anomaly, no prematurity, no weight gain. So metformin, what I do, I start with a low dose, initially 500 milligram every night, and then BD, and then maximum dose which I have given is 1000 milligram BD, and patient they tolerate it very nicely. So hypoglycemia and weight gain with metformin, and one thing is very good about this metformin is that it doesn't allow hypoglycemia and weight gain to occur in comparison to insulin, because when you give insulin, there is risk of hypoglycemia, and also there is risk of weight gain. Only the side effect with metformin, what we see here from the patients are, sometimes they feel nausea, some patient complain of diarrhea, some of heart gain, heartburn or gas. Then I give some PPI and it is controlled. So another is very important, insulin therapy. But if the blood sugar is very high, then we have to add on insulin therapy. Maybe if we give metformin with insulin therapy, the dose of insulin is reduced. So which type of insulin is given? Actually, we use mixed-ard insulin, and it is very safe to be given. And the dose is from 7 unit to 1 unit per kg. This is the total dose, and it has to be divided like 2/3 of the dose is given in the morning with breakfast, and 1/3 this is also the FOXY guideline um, of the MNT and the insulin. So let us see, it is very important. This is diagnosis and management of gestation diabetes mellitus. And the guidelines are of Maternal Health Division, Ministry of Health and Family Welfare of India. So when patient comes, pregnant women Gdm comes to us, we have to give MNT for 2 weeks. If the 2-hour PP blood sugar is 120 or more than 120, what we do is start insulin, and the dose is we give this long-acting insulin with one short-acting insulin. So 30-70 we say. So 30 is the short-acting, that is Lispro, and 70 is the long-acting, that is NPH. And the injection is given subcutaneously and 30 minutes before breakfast initially. When the patient's blood sugar is around 120 or more than 120, suppose. So initially we give only once a day. And the dose of insulin is calculated by the blood sugar. How much insulin has to be given? Initially, once a day we have to give, but how much to be given, it depends upon the blood sugar level. If it is between 120 to 160, start with 4 units. Between 160 to 200, start with 6 units. If it is more than 200, we start with 8 units. Okay, and then say after 1 week or 2 weeks even, we do a fasting blood sugar and 2-hour PP blood sugar. And now what happens if the fasting blood sugar with that amount of insulin is less than 95 and 2 hours PP blood sugar is less than 120, then we continue with the same dose of the insulin, advise her some exercise, and tell her to also take MNT, that is medical nutrition therapy, as we have already discussed. But if the fasting blood sugar is okay, less than 95, but we see that the PP is a little bit raised, it is more than 120, then what we do, we increase the insulin by 2 units. Again, we are not giving it twice. We have, because the fasting blood sugar is normal. So what we do, the pre-breakfast, because PP is raised here, so we are increasing dose of insulin by 2 units in the PP, in the breakfast, pre-breakfast, and MNT and physical exercise is continued. Okay, but what happens when both are increased? Even the fasting blood sugar is more than 95 and PP blood sugar is also more than 120. Then what we do? We give insulin twice, even in the morning and even in the dinner. So morning, so we have added 2 units of the dose, initial dose. Suppose 4 units was there, 695 is more than 95, so we have added 2 units here. But in the evening also we add pre-dinner 4 units, and likewise we keep on testing the blood sugar every 3rd day till it is controlled. So this is all about insulin. So they have said that repeat fasting and 2-hour PP blood sugar every 3rd or 4th day, and we have done it. Very nice slides. This is the same thing. So we have to, when we give insulin, we have to be very careful about hypoglycemia, and it is diagnosed when the blood sugar level is very less than 70 milligram per DL. So we don't require to do very strict control of sugar during pregnancy. So we all know how to manage hypoglycemia. We have to give 3 TSF of glucose powder dissolved in a glass of water, and patient will take a rest and she will become okay. Now comes that was regarding the drug management. Now comes what special obstetric care for pregnant women is required for GDM. The antenatal care in cases diagnosed before 20 weeks of pregnancy. So we have to do as we do in the routine ANC checkup, that at the 11 to 13 plus 6 days we do NT-NB test, and for the aneuploidy, and we also do a Doppler study for the uterine arteries. to look for any risk of preeclampsia. And then at 18 to 20 weeks, we all do anomaly scan. And for all pregnancy with GDM, a fetal growth scan should be performed at 28 weeks gestation and repeated at 34 to 36. What is fetal growth scan? In fetal growth scan, we have to look for the fetal biometry, that is AC, HC, then femur length, then we have to look for the AFI. That is also very important, and of course fetal heart, and also BPD also. And why I'm telling this, because with this we can calculate the fetal weight. Now, the fetal surveillance in pregnant women with GDM. Pregnant women with GDM are at increased risk of fetal death in utero, and this risk is increased in pregnant women requiring medical management. Patients who are on this the MNT or exercise, they don't need such close observation. But these patients who are medical management, even with metformin, we have to very closely observe the patient. But we have to be very vigilant. Fetal heart should be monitored by auscultation on each antenatal visit, which we always do. Pregnant women should be explained about daily fetal activity assessment. Your baby is moving or not, we have to ask the patient. And how do we ask? It is very simple. Tell the patient to lie down on her side after taking her meal. I mean, best meal, I mean, like a lunch. And if she takes good breakfast, or even after dinner, she can lie on her side and count that how much time it takes the fetus to kick 10 times. Suppose in 1 hour, patient kicks more than 5 times, it is normal. But if in 1 hour she doesn't feel any movement, then she has to immediately consult her doctor. Now, how to manage the labor and delivery? Timing of delivery, GDM pregnancies are associated with delay in lung maturity of the fetus. So routine delivery prior to 39 weeks is not recommended. If a pregnant woman with GDM with well-controlled blood sugar has not already delivered spontaneously, induction of labor should be scheduled only after 39 weeks of pregnancy. They are telling that vaginal delivery should be preferred and Caesar should be done only for the obstetric reason. But actually the fetus are normally more than 4 kg, then it is very difficult to deliver her vaginally because there is risk of shoulder dystocia and even injury to the brachial plexus. So at that time, cesarean section. When the baby is more than 4 kg, we should prefer cesarean section. What are the special precautions during labor? When we have induced the patient, or patient has gone into labor, that day we have to omit that time. We are not supposed to give her insulin or metformin, but we have to monitor her blood sugar. And then what we do, we start IV infusion with normal saline, and we do 2-hourly blood sugar monitoring. And if the blood sugar, if we see that blood sugar is between 90 to 120 milligram per dl, then we don't add any insulin. But if it is between 120 to 140 milligram per dl, then to that normal saline, we add 4 units of insulin. If it is between 140 to 180 milligram per dl, there we add 6 units of insulin. And if it is more than 180, we add 8 units of insulin. 8 units means that we have to give 16 drops per minute. And this slide is very important when our patient goes into labor. Even if patient is undergoing cesarean section, we have to keep checking the blood sugar. Post-delivery follow-up. Immediate postpartum care of women with GDM is not different from women with GDM, but these women are at high risk to develop type 2 diabetes mellitus in future. So we have to remember that a patient has delivered, so obviously her blood sugar is going to become normal then, but we have to counsel her to come between 6 weeks postpartum to 12 weeks postpartum for the evaluation of her glycemic status. And she has to be told that there is, because we are doing that because there is a risk of developing type 2 diabetes later in her life, and we have to counsel her about throughout her life. She has to maintain a healthy lifestyle, and she has to pay attention to exercise and her diet. So these we are not going to do. ACOG recommends that insulin to be preferred therapy if glycemic control is not obtained with non-pharmacological treatment. We have already read this. This literature is against glyburide because we have two oral diabetic drugs, metformin and glyburide. Metformin is the preferred drug of choice. We have discussed that. When to deliver? We all know that if patient is on controlled diet, patient is on diet control, we can extend the period up till 39 weeks or more, and expected management up to 40 weeks, 6 days is appropriate with antepartum testing. Well controlled on medication, deliver at 39 weeks, 0 days. But if patient is not that well controlled, then the expert guidance supports early delivery, but data leaking regarding the precise timing. So we have the patient's diabetes is not that well controlled, then we have to deliver between 37 weeks and 38 weeks. If the we have already discussed, if fetal weight is more than 4.5 kg, we have to think for cesarean section, scheduled cesarean section. NICE guidelines now recommend offering continuous glucose monitoring to all pregnant women with type 1 diabetes to help them meet their pregnancy glucose targets and improve neonatal outcome. But it is not possible in our country. We are still following the capillary glucose monitoring, which we are doing with the glucometer. The NICE research recommendations identified a need for qualitative research focused on exploring the barriers to achieve pregnancy glucose target. What are the barriers? The barriers are to examine the effectiveness and accessibility of insulin pump therapy. We don't usually, insulin pump is not available in smaller district hospitals or even in the smaller clinics. So that is for the bigger hospitals or the hospitals which are established for diabetic patients. There they do everything with insulin, but we are not that much using insulin pump therapy. And that insulin pump can be only used when the patient is admitted. For the OPD patients, it is not possible. NICE guidelines did not comment on the role of glucose monitoring for the growing numbers of pregnant women with type 2 diabetes. What still need to improve? Overall, the NICE guidelines bring good news for the pregnant women with gestational and type 1 diabetes, but more work is needed to improve the pregnancy preparation and attention to pregnancy glucose targets, possibly requiring more stringent glycemic targets in pregnant women with type 2 diabetes. In addition to what is this type 1 and type 2, I did not tell you. Type 1 diabetes is diabetes, the gestational diabetes, which are controlled only with exercise and the MNT. But type 2s are those diabetic, gestational diabetic patients who need medical treatment like drugs, insulin or metformin for the treatment of their diabetic status. So gestational diabetes mellitus, at first prenatal visit, screen for undiagnosed type 2. In those, these are the American Diabetic Association standards, which we are not following. So this role of HbA1c diagnosing DCM, Gdm has not been, we have already discussed. The HbA1c is only measured to see the status of fetal complications in the pregnant mother. What are the chances of fetal complications, so that we can terminate the pregnancy? But it is not done for the screening method. Screening method still is in India we follow the Dipsy test. metformin in PCOS women are preventing GDM. Actually, the PCOS women who are on metformin, and if they conceive, then what should be done? Actually, we continue with the metformin. The patient is taking metformin, we don't stop the metformin. Here the line says, in women with PCOS and infertility who became pregnant while taking metformin, there is no strong evidence regarding the preventive effect of metformin or risk of GDM. However, metformin seems to reduce the risk of fetal loss during first trimester. So we don't stop. Even the first trimester we give. What are the glycemic goals? This is very important. What should be the glycemic goals? The treatment goals during the first trimester of pregnancy are not different from those of other trimesters, and include the fasting blood sugar has always to be less than 95, and 1 hour PP has always to be less than 140, and 2 hour PP has to be always less than 120. The treatment goals are based on the suggested values for the second half of pregnancy because there is no conclusive evidence regarding the plasma glucose level during the first half of pregnancy. We have to avoid long fasting. It is recommended to receive 20% of the calorie intake from proteins, 50% from carbs, and 30% from fat with a proper distribution. Is exercise recommended from women with GDM? Of course, it is recommended. What are the goals therapy to control blood glucose? The goal of therapy after 24 weeks of gestation is to reach the fasting blood sugar less than 95 and PP blood sugar after 2 hours less than 120. Now, this is very important. We are worried that if in GDM patient we have to deliver the patient early, then what should be done? Can we give glucocorticoids? Yes, glucocorticoids can be given, but we have to be very cautious. If your patient is on insulin, then the day you have to give glucocorticoid, you have to admit the patient and give the dose, give the glucocorticoid, whatever you want to give, dexamethasone or betamethasone, but you have to increase the dose of the insulin. This is very important. But if patient is not on insulin, then or even metformin, what you do, you have to very closely watch the patient and keep on doing every 2 hours you do for that day the blood sugar level. You have to measure the blood sugar to see if there is any rise of blood sugar or not. Management of how to manage the GDM in COVID era. This is very important. We have to early screening for GDM in hospital, or she can, if she has a glucometer, she can screen at her home also, and HbA1c can be done. If it is more than 6.5%, if the HbA1c is more than 6.5%, it means that she is pre-diabetic. She has diabetic from before that, and we start the treatment as per whatever drugs she was taking, she has to stop, and the insulin has to be started. And if HbA1c is between 5.9 to 6.4, or the blood sugar level is between 160 to 200, ultrasound should be done, and obstetric appointment is required, because there is risk of congenital malformation here, because it is still less than 6.4%. So here there is no risk of congenital malformation. On GDM diagnosis, educate patient on GDM, provide diet plan while one-to-one visit, and plan next visit for checkup accordingly. It really is very difficult in the COVID time. After 1 week via remote consultation, you have to consult on the WhatsApp or and some GDM, some doctors, they have made GDM app, and there they chat with the patients. They advise them regarding the capillary blood glucose. If patient is at low risk, then the obstetric appointment given at 36 weeks. But if patient is of high risk, he is called for regular checkup. Postnatal checkup is needed in both conditions after delivery. Real-time evaluation of the impact of pandemic GDM strategy implementation information with sophisticated real-time data sharing and analysis increasingly available, evaluation of the impact of these pandemic strategies is both visible and vital to iteratively monitor and improve outcomes. Now comes the role of bioinicitol in GDM treatment. Actually, giving insulin is very cumbersome. So, a cumbersome administration method and a high chance of side effects such as hypoglycemia and weight gain have made insulin a problematic and debatable option in the prevention of GDM. So initially, we don't start with actually insulin. However, if a patient, we diagnose a patient of GDM, we start with inositol. I usually do with inositol with MNT with exercise. Based on current evidence, it has been seen that myoinositol supplementation reduces the risk of GDM among obese and overweight pregnant women, as well as women with PCOS or a family history of type 2 diabetes mellitus. Whenever I see a patient with history of GDM in the previous pregnancy, or she is obese, or even she is overweight, or she has history of PCOS, it's better to start with myoinositol. What are the benefits? So let us see. If we give 2 grams of oral myoinositol, as soon as the diagnosis of GDM or pre-pregnancy diabetes has been confirmed, then it is effective in achieving glycemic control. Oral myoinositol supplementation is effective in treating GDM, thus decreasing the need for any pharmacological therapy, and baseline HbA1c is an independent risk factor predicting the need for insulin. Clinical evidence of use of myoinositol. With myoinositol, glycemic control is achieved in 89.8% women. Oral supplementation with myoinositol in dose of 1 gram twice daily when started soon after the diagnosis of GDM is effective in achieving glycemic control and decreasing the need for additional pharmacological therapy in Asian Indian women. It is believed that myoinositol, due to its insulin mimetic qualities, activates glutamine 4 translocation to the plasma membrane and then leads to increase of glucose transport through glutamine 4 into the cells. According to these theories, myoinositol reduces the insulin resistance in pregnancy, and myoinositol supplementation could increase the action of endogenous insulin. Combination of myoinositol and alpha-lactalbumin may reduce insulin resistance and excessive fetal growth in women with GDM. Furthermore, a reduced rate of insulin treatment in preterm birth was treated in the treated group. Even a dose of insulin gets reduced if this myoinositol is started early in the GDM patients. So, to undertake actions in our various capacities to support efforts to address the link between maternal health and diabetes as a public health priority, to accelerate the implementation of the FIGO GDM initiative by pursuing supportive policy actions and mobilizing resources for its implementation. These are the FIGO guidelines which I am reading. The guidelines is there to promote and celebrate a National GDM Awareness Day as an instrument to bring public attention and raise awareness to ensure all pregnant women in attending health facilities are tested for hyperglycemia using a single-step procedure, which we are doing, keeping in mind accessibility and other barriers to offer simple, cost-effective, feasible, and timely diagnostic tests as advocated by FIGO GDM initiative. So the take-home message is gestational diabetes is initially controlled by MNT and exercise. Only few women in whom blood sugar is not controlled by diet and exercise, oral antidiabetic, either metformin or insulin injections are required. GDM can be treated with oral metformin tablets as they do not harm the fetus. Insulin injections are required only during pregnancy. Insulin will be stopped in most of the cases after pregnancy. Insulin injections over abdomen is 100% safe. Modification of diet is very easy. Sweets should be avoided at all times during pregnancy. If blood sugar is controlled, patient and her baby both are safe and healthy. Pregnant women GDM should deliver at health facilities only. It will help in management of any complications which can be encountered during delivery. This is regarding the GDM safe when given from the first trimester prevents the occurrence of GDM in high-risk patients, reduces GDM occurrence risk by 56.3%. In already GDM developed patients, GDM safe helps to reduce insulin dose, prevents macrosomic baby, and adenopectin is a hormone produced by adipose tissue involved in glucose regulation, and adenopectin levels have been found to be low in GDM, and this Bioinicital, when given, increases adenopectin level by 28%. And this GDM surf also contains vitamin D3, and we all know that vitamin D3 decreases fasting blood glucose, improves insulin sensitivity, मतलब कि it decreases the insulin resistance, and by improving the beta cell function of the pancreas. So GDM is the mother of non-communicable diseases. Initial treatment of GDM will prevent its effect for up to 3 generations. When you manage one patient of GDM, you manage her 3 generations. Thank you very much for your listening.
Thank you so much, ma'am, for giving this information regarding GDM. So let me check if we have any queries in the comment section, ma'am. Till then, can I have your permission and play 2 minutes of video of our Shield products, ma'am?
Yes, yes, yes.
Thank you, ma'am. Thank you, ma'am, for giving us your valuable time for sharing this video. So now let me check the queries in the comment section, ma'am. So, ma'am, the first question is, are pregnant women with GDM issue are at a high risk of COVID-19 infection?
No, no, no.
And is there any relationship between iron deficiency and GDM?
Iron deficiency and GDM. No.
Then will metformin reduce the risk of growing gestational diabetes if the patient is taking fried foods and all kind of processed foods during pre-pregnancy?
No, a patient is taking pre-pregnancy. One thing I want to highlight, a patient wants to become pregnant, right?
Yeah.
And before she's pregnant, she's taking all junk foods.
Yes.
So she has to take care of that and take her, her glycemic control should be very good. Because when she is taking junk food, obviously she will become fat. If she is obese, then it is likely that her blood sugar will be raised, because what obesity increases the insulin resistance. If there is insulin resistance, then obviously her blood sugar will be high. If not very high, the borderline high, it has to be there. So she has to be very clear in her mind that if you want to become pregnant, first you have to keep your glycemic control to a very limit. The blood sugar fasting should be less than 95, as we have read, and the PP blood sugar should be less than 120. If it is controlled, then you go to your obstetrician, because still you are not diabetic, but though it is you are at risk of diabetes. Every pregnancy, even everyone is at risk of. So we are doing this Dipsy test so early in pregnancy. So this counseling is very important, and this question is very likely. It's a very important question to be raised. So my answer is that avoid those junk food. Keep on doing exercise, whatever you like. Do yoga, cycling, even walking. And keep your blood sugar always in control before pregnancy, during pregnancy, and after pregnancy, and don't become diabetic. Our country has become diabetic capital of the world. This is my answer to her question.
Sorry, ma'am.
Mm.
Am I audible?
Yes.
Yes, yes, ma'am. So my question was that how do you counsel such patient that who find out that they are diagnosed with GDM, and then they get stressed and have a tension that what will be happening to a baby?
Uh, Actually, so when we do this Dipsy testing early in the pregnancy, and we find that her blood sugar is raised. So it is very simple thing. What I told you, diet control,
Mhm.
diet control. She has to visit a dietitian, or even we suggest that your diet should be. Um, you break your diet. Suppose
Mhm.
you are taking 3 times, no? Breakfast, lunch, and dinner. Then what you do? Take breakfast little. Breakfast, you take breakfast, then you take snack time, then lunch, then again snack time, and then dinner. So you have three main meal and 2 short meals. So you're never hungry. So if you get hungry, what you do? Suppose you take a light breakfast, what you do? You eat so much in the lunch
Yeah.
period. And that time, your pancreas will not support it. You're already insulin resistant state. So if you take small meals at small intervals, you're not hungry, and it is also very good. And take all the complex carbohydrate, avoid white sugar. Some the white things should be avoided. Maida, chini, that is sugar is white, and rice, white rice. 3 things you have to avoid. And take the bajra, oats can be taken. Milk, protein, you have to take 2 glasses of milk or paneer, or this can be taken. Nuts can be taken, green leafy vegetables. So what I say, that a small part of carbohydrate, a little bigger part of protein, and then fat. And after that, you compensate everything with salads, vegetables. And don't fry your vegetables much, because if you fry, the calorie is burned. So for that, you have to keep it a bit raw also. So take whatever you like. Is not we don't tell, because in pregnancy it is very difficult. No, there's so much likeness and dislikeness. So you
Yes.
take whatever you like, but these things have to be added. And take eggs. You can egg. Everybody likes egg. So if you take one time boiled egg, one time omelette, then it will suffice. So that way you maintain.
For giving this answer, ma'am. And last question is that are there any chances of musculoskeletal problems due to GDM in pregnant women?
In the baby, yes, you can. I have shown that picture. Caudal regression syndrome and sacralism. The 2 complications which we have seen. But when that is when the HbA1c is very high, it is more than 25. So we have to control our diabetes so that our HbA1c is less than 6.5. And if in the early pregnancy, what actually earlier we are doing only the Dipsy test, and
Yes.
And if this test was positive, some gynecologists like to do a fasting and PP also. But nowadays we are doing HbA1c also to see the status of the glycemic control of the last 3 months. And if it is less than 6.5, you're not worried. And we don't have to keep on repeating this HbA1c. This thing also I want to highlight.
Okay.
It is not that every month we're doing HbA1c. If once we have done control, then we don't have to do it because it is a costly test. And our country is not that rich. Now we're talking about insulin pump and this and that. We're not doing that. So we have to, when we give any lecture on the to a broader family of ours, then we have to tell what is feasible to everyone. So HbA1c is not feasible every time. Once in her pregnancy, we should do it. And secondly, yes, and this we have to keep one a glucometer. It is very important because every time it is not possible to go to the pathologist to get tested. So it is home monitoring. We have to teach actually what we are doing, in our OPD, when I was in my CCL hospital, used to donate these glucometers to the patients. Like our patients were entitled. So that company, I was working in the Coal India, and that is totally a government company. So we used to have these glucometers, and even used to arrange from our pharma companies to the patient glucometers. They used to feel so happy, and they used to do their test and come every time, madam, this blood sugar is so controlled and this. And government should reduce the prices of these glucometers and all.
Yeah.
And every house should have one BP instrument and one glucometer.
That was very nice initiative from your end, ma'am. So even the pregnant woman should also get trained on how to use the blood glucose meter.
Even insulin, how to give insulin, we train.
Yes.
Because they get so scared when we say that aapko to insulin lagega. They become so frightened and they start. And most of the time they don't take, and this blood glucose uncontrolled. So when we see that type of patients, we try to manage with metformin. I was telling in my, though it was written that it is not safe before 20 weeks, but it is safe. I have given from day one. From day one, my patients and the children have grown up to 19, 20 years they become, and they have no congenital anomaly, any complications later in their life. So
till now.
But if blood sugar is very high, then we have to give insulin. Suppose it comes 300, 260 blood sugar, this Dipsy test, then what do we start with insulin? And then we have to be very polite with the patient, right? And counseling is very important. Better to, if you are very busy practice, I keep on counseling. So they can counsel the patient and they teach everything, how to take monitor blood sugar, how to inject insulin by your side. And one thing, it is not here, I will add in these slides, that at night, 3 a.m., the patient should have a packet of biscuit with her. But that is the time where hypoglycemia occurs in most of the patients. And if there will be hypoglycemia, her baby has the chances of demise. So 3 o'clock, either you take blood sugar should be measured at 3 a.m. or if not possible, just take a bite of biscuit, one biscuit at least, so that will prevent hypertension.
Thank you for giving this advice also. So let me check if one more question is there or not. So there are no further queries. Thank you so much for giving all the answers to our questions to delegates. And I thank you for coming and joining us on Shield Connect, ma'am. And would like to have more sessions with you on our platform, ma'am. Yes, thank you so much, ma'am. So we can wind up this session. Thank you, delegates. Bye, ma'am.
Thank you, everyone, for bearing with me and hearing me.
Thank you, ma'am.